Good afternoon, ladies and gentlemen. My name is Antonia Dimitrakopoulou-Strauss from the German Cancer Research Center in Heidelberg. My topic is immunotherapy monitoring with PET-CT in cancer patients. As you know, imaging modalities are in general divided into morphological and functional methods. Morphological methods are ultrasound, CT, and MRI, and functional methods are primarily SPECT, PET, some MRI sequences, and there are also some newer methods like optical imaging and photoacoustic imaging, but these methods are primarily used in preclinical imaging and
Sorry, I'm on two different computers.
Good afternoon, ladies and gentlemen. My name is Imaging modalities are in general divided into morphological and functional methods. Morphological methods are ultrasound, CT, and MRI, and functional methods are primarily SPECT, PET, some MRI sequences, and there are also some newer methods like optical imaging and photoacoustic imaging, but these methods are primarily used in preclinical imaging and not so much for patient studies. Now, as you know, with morphological images, you measure normally one parameter like the transmission when you use CT. On the other side, using functional imaging methods, you can measure different parameters which depends on the tracer you apply. For example, if you apply FTG, you measure the glucose uptake, and so on. Now let's come to the applications of PET in oncology. The indications are the same since the introduction of the methods in oncology. These are primary diagnosis of a mass, staging, assessment of tumor recurrence, and monitoring of therapy response. Now, I'd like to speak a little bit about the role of PET in the era of personalized medicine. In general, the role of imaging in the era of personalized medicine is crucial, and this will increase in the near future, together, of course, with other approaches like omics technology, genomics, proteomics, and so on. Large image-based screening programs will be increasingly for personalized cancer prevention, for example, for lung cancer, breast cancer, or prostate screening. Of course, not only PET, but CT and MRI are included. Now let's come in particularly to PET. What will be the role of PET in the era of personalized medicine? To my opinion, PET will be used for the improvement of tumor diagnosis by using dedicated tracers like PSMA for the diagnosis and management of prostate cancer. Another very important application of PET is the tailoring of therapy based on PET-CT for therapy response assessment. What does tailoring mean? Tailoring means the choice of the appropriate therapy and dose, the optimal treatment duration, the early identification of non-responders, treatment escalation or abbreviation or change or maintenance therapy, and furthermore, guided invasive intervention. It means that by using PET, you can guide biopsy. Now, let's come to the molecular imaging tumor box for PET. You can imagine you need dedicated tracer in order to do a good diagnostic and also for theranostic approaches. We have two very good examples for that purpose. This is Dotatope and PSMA, which can be used for both diagnosis and treatment. But what we do not have to such a degree are tracers, dedicated tracers for immunotherapy monitoring. Until now, for immunotherapy monitoring, markers conventional markers for viability or proliferation or amino acid metabolism are used to do immunotherapy monitoring. And I will show you some examples. On the other side, what is also needed are new tracers, which are in use, in preclinical use at least, and in limited clinical use. And these tracers are, for example, gallium-68 copy, which visualizes the cancer-associated fibroblast. Furthermore, it's possible, at least in preclinical studies, to do PD-1 or PD-L1 imaging by labeling therapeutically substances like nivolumab, which is a PD-1 inhibitor, or atezolizumab, which is a PD-L1 inhibitor. What we need besides these tracers are dedicated tracers for the so-called T-cell trackings. T-cell tracking can be done by labeling CD4, CD8, or by labeling CAR T cells, and in order to do CAR T cell imaging. This is a diagram which looks really complicated, but I like to ask you to focus on the right and on the left side. If you look at the right side, you will see a lot of tracers which are in use for clinical purposes for immunotherapy monitoring. So most of these tracers are related to metabolic pathways like FTG, or proliferation tracers like FLT or labeled amino acids. Furthermore, you can use receptor imaging also for immunotherapy monitoring, like chemokine imaging, or you can use transporters like the natrium iodide importer and so on. So all tracers on the right side are related to tumor metabolism and are in use. What is new are the tracers here on the left side, because all these tracers are related to T-cell function. And you can see here that it's possible to label, for example, PD-1 or PD-L1, or you can label CTLA-4, which is also used for treatment with immune checkpoint inhibitors, or you can label antibodies against OX40, or you can even label directly T cells like CD8 or CD4. Let's take a closer look to the immune checkpoints. Tumor can use checkpoints to protect themselves from immune system attacks. And this graph shows the most important immune checkpoints, which are the PD-1, PD-L1 axis and the CTLA-4s. The PD-1 sits on the T cells as well as the CTLA-4. CTLA-4 means cytotoxic T lymphocyte antigen 4. And PD-1 is the programmed cell death 1 protein. So the problem is the following. If the PD-1 binds to the PD-L1, which sits on the tumor cell, then the T cells became inactive. The same is true for the CTLA-4. If the CTLA-4 binds to the B7, then again the tumor T cells are inactive and they cannot attack the tumor cells. So what we need is a substance which is an antibody in this case, like nivolumab or pembrolizumab, which blocks the binding from PD-1 to the PD-L1, or another substance, an immune checkpoint inhibitor, is ipilimumab, which is an anti-CTLA-4. It means that ipilimumab blocks the binding from CTLA-4 to the B7. So if this binding is prohibited, then the T cells are active. And this is the principle of the immune checkpoint inhibitors. This slide is from a very nice review from Gambir et al., which was published in the Journal of Nuclear Medicine in 2018. And it shows the different possibilities to label biomarkers for T-cell imaging. So the first approach is to label an endogenous target. For example, you can label an antibody against the PD-1 or the PD-L1, like I showed before. For example, it's possible to label pembrolizumab, nivolumab, or CTLA4. So in this case, you are doing PD-1 or PD-L1 imaging. Another approach to label a reporter gene, which is used for CAR T-cell therapy. And if you do that, you can do CAR T-cell imaging. I will show you later an example of this approach. And the last approach is to direct label T-cells. For example, as I mentioned before, it is possible, at least on an experimental level, to directly label T-cells, activated T-cells like CD4 or CD8, or to label dendritic cells. Now, some examples. These examples are from this interesting review paper from Gambir et al. On the upper row, you see PD-L1 imaging. This is a CT image in a mouse with an anti-PD-L1 gold nanoparticle, shows the enhanced PD-1 receptors here in the tumor, which is very large. Here you see an optical imaging again with PD-L1. On the right side, this is a PET image with an anti-PD-L1 antibody. The advantage of PET is the very high contrast, as you can see here. These are examples of imaging of activated T cells. On the left side here, you see a PET image with a copper DOTA antibody against OX40 after intratumoral vaccine therapy. Here in the middle, you see a CAR T-cell imaging. This is a patient with a recurrent glioblastoma who got therapy with CAR T-cells. And by labeling a reporter gene, you can see that it's possible to visualize the result of the CAR T-cell therapy. And on the lower row, you see some other images which are quite experimental. This is optical imaging of myeloid cells. In red, you see the macrophages. In yellow, the PD-1 cells. And in blue, the T cells. In the middle, this is an MRI image of dendritic cells. Here, this is a lymph node metastasis. And on the right side, it's an fused image of F19 and H1 MRI after intradermal dendritic cells therapy. Now, let's come to some more clinical examples. This is a very interesting paper published by the group of Niemeyer and all, and in the Nature Communication in 2018. And I think this is the first paper reporting on anti-PD-L1 imaging in patients with lung tumors. On the left, these are two different patients. The upper row shows one patient with a lung tumor, a big lung tumor here in the right lung, and some metastases in the left lung, and here also in the right lung. This is the FDG imaging showing the tumor viability in all these viable tumor parts. In the middle, you see the anti-PD-L1 imaging with a substance which is anti-PD-L1 adnectin labeled with F18. And what we see here is that there is an enhanced PD-L1 uptake here in both tumors and in the metastases. And on the other side, it's the same patient, this time after injection of zirconium-89 labeled nivolumab. So again, this is PD-1 imaging. PD-1 imaging shows again an enhanced uptake in the tumor, but it's not so high as by using this adnectin tracer. And also in the left tumor, you have an uptake, but it is not really high. But the example shows very nicely that it's possible in parallel to tumor imaging with FTGs, with viability imaging, to visualize PD-L1 receptors in the whole body, which is not possible if you acquire just one biopsy. In the lower rows, you see another patient with a lung tumor again. This patient has a lung tumor which is avid in FTG, but not with very high FTG uptake. In the middle row, you see the uptake of the F8 and BMS, which is low, much more lower than in the other patient. And here the uptake after tracer injection of zirconium-89 labeled nivolumab. Again, the uptake here is low. So you may have a high and enhanced uptake of PD-1 or PD-L1 or a low uptake. But in any case, the interesting thing is that you can visualize the PD-1 or PD-L1. This is a very nice example published in Theranostics in 2019. And what we see here is direct T-cell tracking. This is a patient with a primary hepatocellular carcinoma located in the right liver lobe and one metastasis. And the images are after 12 weeks of immunotherapy. So the patient got for 12 weeks immunotherapy, and then he got a tracer injection of zirconium-89 labeled anti-CD8 minibody, and this is the fused PET-CT image. So what we see here is the direct invasion of CD8 cells as a result of a good immune response. We do not see viability, but we see the infiltration of the CD8 cells into the tumor. The MIP here shows that, of course, there is an uptake in the spleen, in the bone marrow, and in some lymph nodes, which is normal. But interesting is the T-cell infiltration directly in the primary tumor and in his metastatic part. Now let's come to the problems of immunotherapy monitoring with FTG. In my talk, I will focus on melanoma, because melanoma is the tumor which was first treated with immunotherapy with immune checkpoint inhibitors, and this approach was very successful. Most of the studies on immunotherapy monitoring melanoma and also in other tumors are performed by FTG. And if we are doing immunotherapy monitoring with FTG and PET-CT, we deal with several problems. One problem are the response criteria. The non-response criteria for PET-CT are the EORTC and the PERSIST criteria. EORTC were defined by Young et al. In 1999, and EORTCs were based on solid tumors and on cytotoxic chemotherapeutic approaches. So it's these criteria are actually not the proper one for immunotherapy monitoring. The other set of criteria are the so-called PERSIST criteria, which were defined in 2009 by Richard Gore and al. And also these criteria are based on solid tumors and the chemotherapeutic approaches. The criteria are quite similar. A major difference is the different cutoff. So here I have a cutoff between 15 and 25%, and in the PERSIST criteria, the cutoff is about 30%. But these criteria are not proper for immunotherapy monitoring, because one new lesion in both sets of criteria are related to progressive disease, and this is not the case for immunotherapy monitoring. Let me show you our first results in patients with metastatic melanomas. We started this study in 2010 in patients with metastatic melanomas, melanoma stage 4, who got monotherapy with ipilimumab because at that time no other immune checkpoint inhibitors were FDA approved. Ipilimumab was quite good with a response rate of 11% and the control of disease in 22% of the cases. This is a prospective study. We did 3 studies, a baseline study prior to onset to immunotherapy, then a follow-up study after the completion of 2 cycles of ipilimumab, and a third study after the completion of 4 cycles of ipilimumab. The key question at that time was if the early follow-up after 2 cycles was predictive as compared with the late follow-up after the 4 cycles, because 4 cycles was the maximum dose for the patients at that time. Another question was how much is the percentage of pseudoprogression, because at that time it was believed that pseudoprogression is a very important limitation for doing FDG PET-CT, but our results did not support this suggestion. So we could examine 44 patients with metastatic melanoma, 3 PET-CT studies, and the patients were first classified according to the clinical benefit. So we dichotomized the patients into patients with complete response, partial response, and stable disease. 31 patients had clinical benefit and 10 patients showed progressive disease. The idea is that melanoma patients with stable disease are classified to the group with clinical benefit because prior to the introduction of the immune checkpoint inhibitors, the survival rate was approximately 6 months. Let me show you some representative examples of follow-up cases in patients with ipilimumab monotherapy. This is a patient with a large package of metastasis in the left lung and in the surrounding thoracic wall, and you see that there is a clear disease progression if you look at the follow-up studies. So this is the baseline, the study after 2 cycles, after 4 cycles of ipilimumab, and then 1 month after 4 cycles. So in this case, the results are consistent, and the first follow-up was predictive with respect to the late follow-up. So everything is okay. But we had also different distribution patterns. Here you see an example of a patient who showed a progressive disease in the first 3 PET studies, and then 2 months later he showed a response without any immunotherapy. The reason is that some patients, but not too many actually, may show a late response to ipilimumab monotherapy. This is good for the patients, but it causes problems for predicting the therapeutic result. But this is one possible therapeutic pattern. We published these results, Christos Apogidis published them in the European Journal of Nuclear Medicine in 2015. And we found for the first time that the lesion-based SUV, here in blue, and also the patient-based SUV was not statistically significant in the group of progressive disease as compared to the group of patients with stable metabolic disease. But what was really different was the number of new lesions. So patients with progressive metabolic disease demonstrated much more new lesions as compared to the patient with stable disease. And if you look at the Kaplan-Meier curves here, you see that patients who were classified as stable metabolic disease, these are the red curves, in the early PET and in the late PET, all these patients showed a longer progression-free survival as compared to the patients who were classified as progressive metabolic disease. Now let's come to the pseudoprogression. The question is the interim FDG PET predictive? We found that it was predictive in approximately 90% of the patients. We observed an early pseudoprogression like in this patient here, only in 2 out of 22 patients. And furthermore, as I mentioned before, we found a significant increase in the number of new lesions in the group of the progressive disease, and also an SUV change more than 48%. This is a good example of pseudo progression. This is a patient who clearly shows a progression in the early and in the late bed, but then 1 month and 4 months later, all lesions disappeared. So this was an example of pseudo progression. So all of these problems are not new. Therefore, several groups and also international societies try to define new criteria for immunotherapy monitoring. And these are the criteria published by the group of Hulhop and all in the clinical cancer research. These criteria were the first one, and they are called immune-related response criteria. So they defined 4 groups. And immune-related complete response was related to the complete disappearance of all lesions, whether measurable or not, and when no new lesions were there. Immune-related partial remission was defined as a decrease in tumor burden more than 50% as compared to the baseline study. Immune-related stable disease means that this group of patients do not meet the criteria either for complete response or partial response or progressive disease. And immune-related progressive disease was defined as an increase in tumor burden more than 25% as compared to the baseline study. Now, what is new in this criteria set? New is that the authors proposed to look at the whole tumor volume, so not just to measure one lesion, but to look at the whole tumor volume. And the second thing which is new is that they recommend a follow-up study no less than 4 weeks from the first study, from the baseline study. So these 2 criteria are new. And this is a slide from the same publication. This slide shows the different response pattern which can be obtained after immunotherapy monitoring with ipilimumab, but also with other immunotherapeutic protocols. On the upper left, you see an example of complete response. This is clear. So we have a clear decrease of the whole tumor volume and no new lesions. So that's not a problem to classify such a case as a complete response. This is an example of a stable disease. In this case, we have a small increase, which is less than 25% of the tumor volume, followed by a clear decrease of the tumor volume. This is classified as stable disease. And now let's come to the 2 new response patterns which are not observed with the chemotherapeutic agents. The one is the pseudo-progression, as I mentioned before. In this case, you may have an increase of the tumor volume up to more than 100%, followed by a decrease of the tumor volume, like here. So we have to be aware of such a response pattern. And the most complicated response pattern, to my opinion, is this response pattern here. So in this case, we have a combination of a decrease of the total tumor volume of the baseline. It means if we exclude the new lesions, but in parallel to that, we have new lesions which decreased within the follow-up time. And overall, if you add both tumor volumes, the one from the tumor for the new lesions and for the older lesions, you have a small increase, which is less than 25%, followed by a decrease. And this pattern is a pattern which corresponds to partial remission according to these criteria proposed by Goldhock. Now, in the meantime, several other response criteria are defined, like the iRECIST. iRECIST are comparable to the RECIST. The major difference is the introduction of the term unconfirmed progression and the term confirmed progression. It means that the group recommends a follow-up study in between 4 and 8 weeks after the baseline study in order to confirm or not the results of the early follow-up, let's say. So the repeat of the follow-up study between 4 and 8 weeks is a major criterion in this response criteria. And now let's come to our results back. We looked at our data, and as I told you, we found that the number of new lesions is a strong parameter more than the change in the SUV. And therefore, we try to classify the patients into the two groups, into the group of progressive disease and non other patients, because all other patients had a clinical benefit from the ipilimumab. And for this purpose, we first compared the baseline study to the late study after 4 cycles of ipilimumab. So we looked at the number of new lesions. We did here an ROC analysis, and we found that we found a cutoff of 4 lesions of any size. If you use a cutoff of 4 new lesions, you can classify the patient into progressive disease and all other groups by a sensitivity of 84% and a specificity of 100%. The next step was to look also at the diameter of the lesion. So we thought to combine the number of lesions with the diameter of the new lesions, and this combination resulted in the following result that if you just have lesions which are more than 1.5 centimeter in diameter, 2 lesions are enough. So 2 lesions with a diameter more than 1.5 centimeter can be used as a criterion to classify patients into progressive disease and all other groups, with a sensitivity of 94% and a sensitivity of 90%. And this led to the definition of these so-called PERSIMT criteria. We published them in the Journal of Nuclear Medicine in 2018. And the major difference to the known ERTC criteria is only the definition of progressive disease. With the ERTC criteria, 1 new lesions means progressive disease, but with this PERSIMT criteria, we found that the progressive disease is associated with more than 4 new lesions of less or more in functional diameter, or more than 3 new lesions of more than 1 centimeter in diameter, or more than 2 new lesions of more than 1.5 centimeter in functional diameter. The next step was to look if this PERSIMT criteria also work for the evaluation of the early follow-up. It means after 2 cycles of ipilimumab. Therefore, we compared the baseline study prior to onset of ipilimumab with the early follow-up after the 2 cycles. And we used both the ERTC and PERSIMT criteria, and we found that the accuracy by using the PERSIMT criteria was 87.8% as compared to 70.7% using the ERTC. So PERSIMT criteria performed better also for the evaluation of the follow-up study. The next step was to assess this criteria in patients with pembrolizumab, nivolumab, and so on. Because as you know, ipilimumab was the first immune checkpoint inhibitor, but some years later, newer immune checkpoint inhibitors, the so-called PD-1 inhibitors, were used, and these PD-1 inhibitors like pembrolizumab or nivolumab are much more better concerning the progression-free survival and the overall survival. In this publication, in New England Journal of Medicine of 2015, The authors found that the 12-month progression-free survival is 74% for pembrolizumab as compared to 58% for ipilimumab. So it's a great difference between the two traces. This is an example of a patient treated with pembrolizumab, and this shows very nicely that it's possible to tailor therapy using PET-CT. This patient had several liver metastases in the baseline study and also some metastases located here. After 2 cycles of ipilimumab monotherapy, we had a very clear progress of the disease. So the oncologist thought that it's a good idea to stop the therapy and to use pembrolizumab, which was just approved at that time. And interestingly, when the patient got the pembrolizumab, even after 1 cycle, all metastases disappeared. So this was a very nice, complete remission. These are the PET-CT images, the fused images of the liver metastases prior to pembrolizumab, after 1 cycle of pembrolizumab, and even 7 months after pembrolizumab therapy, the patient was in complete remission. Another example showing how we can use FDG PET-CT for tailoring immunotherapy is shown here. This was another patient, a baseline study with several lung metastases in both lungs and 1 metastasis here in the upper leg. After 2 cycles of ipilimumab, again, no response. Therefore, oncologists stopped therapy and they changed therapy to a combination of ipilimumab and vemurafenib. The reason was that this patient has a BRAF mutation, so vemurafenib works in this case. And as you can see here, all lung metastases disappeared after this combined immunotherapy. Now, the next step was to compare the PERSIST criteria to the ERTC criteria in patients getting anti-PD-1 treatment, like pembrolizumab or nivolumab, or a combination of both nivolumab and ipilimumab. If we look at the data comparing the combined immunotherapy to the monotherapy with PD-1, we see that the Kaplan-Meier curves show clear longer progression-free survival in patients who get the combined therapy as compared to the monotherapy. Then we looked at the performance of the ERTC and the PERSIST criteria in patients receiving PD-1 therapy. And we see here in the Kaplan-Meier curves that with both criteria, it's possible to differentiate between patients who benefit from the immunotherapy or not. And with both criteria sets, patients who classified as responder showed a longer progression-free survival. Interestingly, using the PERSIST criteria, the difference was statistically significant, whereas using the ERTC criteria, the difference was not statistically significant. Now I come to the last topic of my talk, which is the visualization of immune-related side effects of immunotherapy. We know that up to 80% of the patients who get ipilimumab show immune-related side effects like enterocolitis, hepatitis, endocrine toxicities, pneumonitis, arthralgia, ocular toxicities, and so on. And it is possible to visualize these immune-related side effects in PET. For example, here you see a clear example of colitis, or here we have a patient with thyroiditis. This has an impact because if the oncologists know these side effects, then they treat them, and this is good for the patients. Another example is this patient here. This patient was treated with PD-1 with pembrolizumab, if I remember correctly. And we have here the classical distribution pattern with an enhanced FDG uptake due to arthralgia in the knees and also in the shoulders. But which is the most interesting thing is that this patient showed a sarcoid-like reaction in the mediastinum, This case was confirmed by biopsy, and this is something which is seen relatively often in patients who get anti-PD-1 therapy. So we have to be aware about this symmetrical enhanced FTG uptake in the mediastinum, and we have to be very careful and even to do a biopsy and not automatically classify such a case as a progressive disease. In this first study, we even found that patients with immune-related adverse effect showed a longer progression-free survival as compared to those who did not have any immune-related adverse reactions. But in the other study we couldn't confirm these results, so the literature is divergent about this topic. So it's open if the presence of immune-related adverse effect is good with regard to progression-free survival or not. And now I like to close my presentation. I think that immunotherapy monitoring is a complex situation. Of course, imaging plays a role, but imaging alone is not enough. We have to combine methods. We should look at other blood cytology markers or markers associated with systemic T-cell response. Of course, we should do a combined evaluation of imaging with, for example, imaging data, genomics, proteomics, or whatever. We have to look at tumor mutation or at neoantigen load, at expression of immune-related genes, and of course, we have to look at all these T-cell parameters like CD8, CD4 infiltration, and so on. And last but not least, my conclusion is that, to my opinion, FTG is a valuable tracer for immunotherapy monitoring, with the limitation mentioned before. And of course, new dedicated tracers are needed because it would be very nice to do not only FTG monitoring, but also PD-1 or PD-L1 monitoring in order to see the PD-1 or PD-L1 expression. Another point is the definition of new response criteria for PET-CT and immunotherapy monitoring. And there will be a publication about this in the European Journal of Nuclear Medicine about new criteria sets. And overall, it is known that PET-CT provides superior information due to the combination of anatomic and functional information. So it's better to perform a PET-CT than to perform just a diagnostic CT or a diagnostic MRI alone. Pseudo progression is a limitation, but it is not a major limitation. It's less than 10% in the literature. So this means that we can use FTG, and we have to be careful about pseudo progression and about unspecific reaction due to immune-related adverse effects. I'd like to thank you for this presentation. Thank you very much.